Anyone who suffered from trigeminal neuralgia knows it's one of the worst, most painful, disabling conditions there is ever. And I've seen people both in the acute phase and the chronic phase. I mostly see chronic trigeminal neuralgia, so I don't normally see the patient when they first get trigeminal neuralgia, because often acutely when it first hits and it's so debilitating, and normally trigeminal neuralgia, it's severe lanciating pain, like sharp, awful, like you're getting electrocuted, and it's normally in the V2 portion of the trigeminal nerve, which we'll talk about. It's so easily recognized, so it's one of those conditions that gets diagnosed early and correctly. So the neurologists, the family physicians often will just give high-dose steroids, and then, you know, a decent amount of people, they get resolution of it, or eventually a person will get referred to a anesthesiologist who will do various nerve blocks into it. I've done those things too, you know, where you can get to the trigeminal nerve by this trajectory with a needle. You'll get to the ganglion, the trigeminal ganglion, which is basically right here, and then there's the 3 branches of the trigeminal nerve. Oh, I'm not supposed to touch the screen, so I already touched the screen. They just cleaned it. So the anesthesiologist will do steroid shots or nerve blocks, or they do radio frequency ablation. So they ablate the nerve, which basically decreases the symptoms of trigeminal neuralgia, and sometimes the disease just stops. So note, I'm mostly talking about chronic trigeminal neuralgia when somebody's had it for a long time, nothing's helped, they've seen everybody, now they're at Caring Medical. So the trigeminal nerve, it originates from the pons, which is part of the brain stem, and then the tract goes in the spinal cord all the way down to C3. This is a very important point. The trigeminal cervical nucleus, in other words, the nerve tract for the trigeminal nerve, can go all the way down to the C3 level, So that means that stimuluses of the upper cervical region, for instance, upper cervical instability can irritate the nerve tracts for C1, C2, and then those can irritate the trigeminal nerve, and you can get symptoms of trigeminal neuralgia. So I just want to say that again. So there's a trigeminal cervical nucleus that has nerve cells from the C1 nerve, C2 nerve in the upper cervical region that go to the same place in the spinal cord as the trigeminal nerve. So let's just talk about chewing. So somebody chews. The trigeminal nerve innervates the muscles of chewing, like the masseter muscles or the pterygoid muscles. So you're chewing. And that stimulates the trigeminal nerve, which goes all the way down to C3. And let's say with chewing that you're a patient who then gets horrible neck pain. Like you get horrible neck pain back here, and you're like, what the heck? I'm not doing anything. Well, you're chewing, and the chewing is stimulating the trigeminal nerve, and then it can manifest in symptoms in the upper cervical region because of the trigeminal cervical nucleus. So also, if somebody has upper cervical instability, then that upper cervical instability can stimulate the trigeminal cervical nucleus, and you get trigeminal neuralgia. So that's one way that cervical destructure or problems in the neck structure or instability can cause trigeminal neuralgia. There's basically 3 branches of the trigeminal nerve. There's V1, V2, V3. V1 is called the ophthalmic nerve, V2 is called the maxillary nerve, V3 is the mandibular nerve. Most of the things that I see is V2 or the maxillary nerve. So somebody has severe pain in this region. The 2 most common instabilities that I see with that condition are on that side, the person will have TMJ. So if you have chronic trigeminal neuralgia and you go like this, and on the side of the trigeminal neuralgia you have clicking or popping or grinding of your TMJ, you have to address the TMJ instability, and I would say the best treatment for that is prolotherapy to the TMJ. The other way to tell whether you have a TMJ problem, even if you don't have clicking, is you go into a mirror and you open and close. And then either with opening or closing, you notice one of the TMJ joints pops out. That's the side that you have instability. Even if you don't feel a clicking or hear a clicking, if you'll see that it pops out, so the condyle of the mandible is popping out or subluxing. So you can have instability where you just get a subtle subluxation. And what I find is that when we do cone beam CT scans, on the side that it subluxes, that's also a side that you have an elongated styloid, because the mandible subluxing out. So one of the ligaments that keeps the mandible in is the stylomandibular ligament. So over time, if you've had this condition for a long time, that tension on the stylomandibular ligament causes an ossification of the stylomandibular ligament, or what it's called as an elongated styloid. You might say, well, why are you telling me about this, doc? Well, then there's a whole bunch of nerves like the glossopharyngeal nerve and vagus nerve that can get damaged from that. So you have basically additional stimulus to the upper cervical region. And again, it's not going to make trigeminal neuralgia better. It's going to make it a lot worse. So the two most common instabilities associated with chronic trigeminal neuralgia symptoms is TMJ on the side of the neuralgia and upper cervical instability, specifically at C1, C2. So you have the trigeminal nerve, you have the three branches, and then basically the nucleus goes all the way down to C3. So occipital atlanto C0, C1 instability can be a cause, in my opinion, of trigeminal neuralgia, C1, C2 instability, or C2, C3. There's lots of different mechanisms of it. I explained one mechanism, irritation of the trigeminal cervical nucleus. Another cause would be if atlas misalignment is notorious for causing a CSF blockage. Like ask any upper cervical chiropractor and they'll say, when they adjust the atlas, there's lots of symptoms that get better, and one of the mechanisms they'll tell you it basically frees up cerebral spinal fluid flow. And you might say, well, doc, how does that relate to trigeminal neuralgia? Well, basically all the cranial nerves, and these are all the cranial nerves, and the cervical nerves, including C1, C2, C3, they're all surrounded by cerebral spinal fluid, as is the spinal cord, as is the brain. So anytime you have atlas misalignment, that occurs. Why? Because people have upper cervical instability. The atlas, which is C1, is connected by capsular ligaments to the occiput, the occipital condyles. There's one here. Then the atlas is connected to the facet joints of C2, which we call the axis. That's surrounded by capsular ligaments. So the main ligaments that we tighten with prolotherapy are the capsular ligaments. Then if you have an atlas misalignment that's obstructing cerebral spinal fluid flow, the cerebral spinal fluid flow has to go somewhere, and where it goes, like if it goes around the trigeminal nerve, it could, one, irritate the trigeminal nerve where you get neuralgia. Neuralgia just means that there's electrical impulses going through the nerve, but it's not damaging the nerve. Neuropathy is when the nerve gets damaged. So that's the difference, neuralgia, neuropathy. Neuralgia just means that something is pressing on, stretching, irritating a nerve, and it's like electricity. And I've had that in my C6 nerve root on my right. So in other words, I had basically an injury at my C5 to C7 area with weightlifting, Ironman training, and then the vertebrae subluxed, and I had irritation continuously of my C6 nerve root for 2 months. So for 2 months, complete agony. On a scale of 0 to 10, the pain was like 100, and I still had to work, and the whole thing was horrible. And it took the combination of mostly prolotherapy, but some chiropractic care, and over the course of 2 months, fortunately for me, I got resolution of it. But any sort of nerve, think of it this way: if I touch a nerve, if Dr. Hauser touches a nerve with a needle, like, you know, immediately the person's like, oh my God, like, you know, there's a startle response, and that's what it is when nerves are irritated. It's horrible. So, and I'll present a case here where the person had 10 to 15 of these jolts every hour. It's awful. So this just explains how, you know, there's all the different cranial nerve problems. So this is the case study, 49-year-old who's a patient recently, and then it explains that he had TMJ, so he has chronic trigeminal neuralgia, tried everything, nothing worked. Then what we did was, all we did was do a chiropractic adjustment. We showed him what anatomy he had to be in, so his jugular veins weren't compressed, the vagus nerve wasn't compressed, and sometimes that's, you know, rotating your head a certain way. So we actually do ultrasounds to see what position the jugular vein and the vagus nerves aren't being compressed. And then we told them a certain kind of way to sleep. Then I did prolotherapy in the unstable areas. So in other words, we're helping him get in the ideal anatomy for his neck curve to be optimized, and all the structures in regard to the neck being in their relaxed position. So in other words, there isn't anything here that has to do with any injections in the trigeminal nerve. I'm not giving him steroids. It has nothing to do with that. It's just optimizing the neck curve, optimizing alignment, and then doing something for his upper cervical instability. So when I went into the room, the history taker told me he's 98% better with only the first visit. So I just show this case. Obviously, there's other trigeminal nerve cases that take a lot longer, but basically, you know, he was sleeping through the night, and you know, I did do his TMJ. So I addressed the TMJ instability and the neck instability, and the results were remarkable. So trigeminal neuralgia, like any neuralgia, is an irritation of the nerve. If the nerve gets inflamed, we call it neuritis, and when the nerve cells start dying, that's called neuropathy. There's neuralgias, neuropathies all over the body, and almost all of them you could correlate to joint instability. Example, if you have clicking, popping in the wrist, and then you have symptoms of carpal tunnel, the joint instability in the wrist is causing a movement of the bones, so the tunnel for the median nerve to your hand is narrowed, and then you get carpal tunnel. So you don't need surgery, you need prolotherapy. Or if you have, the doctor said the piriformis muscle is in spasm, that's causing compression and sciatica, and the piriformis is in spasm to try to stabilize something like your hip, or it's under tension because you have sacroiliac instability, then the treatment to resolve the issue is going to be prolotherapy to the sacroiliac joints. It's a common thing even on the internet or whatever, when you guys comment, they're like, come on doc, I have a trigeminal nerve thing which is up here, and then you're saying to me that it's related to the neck. Well, you sort of know it's related to the neck. Why? Because you have other neck symptoms. So anyone with chronic trigeminal neuralgia, if you have clicking, popping, grinding in your jaw, like obviously that would be an indication that the TMJ is involved. But if you know, it's not like my neck doesn't click, pop, or grind when I move it. If you're somebody who self-manipulates, you get a lot of chiropractic care, you have clicking, popping, grinding in your neck, and you have trigeminal neuralgia, you have to assume that there is a correlation. Or if you have other symptoms that we talk about with upper cervical instability, you have tinnitus, ringing in the ear. So you have left trigeminal neuralgia, then you have ear fullness in this ear, or you have secretions coming out of your ear on your left ear, you have hearing loss or decreased hearing on your left side, you have tension, right? If you have trigeminal neuralgia symptoms, say on your left side, and you know that up in the upper neck region, you always have muscle tightness, like those are signs that the problem is an upper cervical instability problem. Somebody who has sleep, who has swallowing difficulties, they have maybe headache with it, they have dizziness, you know, they have other signs and symptoms of cervical instability. I would just say that you should get a consultation to look for upper cervical instability or a reversal of your cervical curve, which I call cervical destructure. So I just want to end this by saying chronic trigeminal neuralgia can be helped a lot. Look at your own neck curve, your own TMJ, as possibly the joint instabilities that are causing your trigeminal neuralgia, and get help to relieve the joint instabilities. The way we do it is with prolotherapy.